a lot of procedures that he has laid down, namely the skip flap, the DF flap. These are some things which I think the younger generation should be aware of. His work on perforator as a director of the perforator to perforator course, which he had in Tokyo, is really spectacular. And his conceptualization and nano microsurgery principles is something which is not believable at all. It is very, very difficult to conceptualize the ideas that he comes through. And we are looking forward to what he's going to say today. So he's going to talk to us on Orochi flaps for aesthetic reconstruction of the hand. That's, I think, his first talk. Okay. Yes, Professor Koshima, please.
Thank you, sir. It will be a pre-recorded talk. I'm going to start it. Meanwhile, we have Dr. Narushima who has joined us. Professor Narushima has joined us. Probably he'll be the next speaker. Thank you, sir. Thank you for the introduction.
Hello, everybody. Today I'll talk on the Orochi combined flaps for session. Also, now we are in a new era from super micro to nano microsurgery for hand surgery. This is my COI described here. Also, this is another COI, newest publication on surgical treatment for lymphoedema, translated in both in Japanese and also English. For these 40 years, after establishing the perforator concept, the pedicle vessel of the free flap become shorter and shorter. Nowadays, the pedicle was within at the level of the adipose tissue, very short pedicle. So free perforator flaps could be classified as a long vascular pedicle, conventional perforator flap, and also a true perforator flap, very short perforator within the adipose tissue. Over 0.3 millimeter, or sometimes less than 0.3 millimeter pedicle vessel. This needs a nano micro technique. Also, short segmental pedicle, T-shaped pedicle is very, very useful as a flow-through pedicle flap. So, perforator flap was popularized after the first international course on perforator flap, 97 in Belgium, Ghent University. Young generation about 30s coming this life cycle course, and nowadays they become over 50s. And for these 30 years, perforator concept popularized all over the world. And nowadays, we are established the international course on supermicro surgery since 2017. So young generation are now educated by this new supermicro concept. Today I'll talk on the Orochi combined flaps for hand reconstruction. So Orochi flaps are completely different from Chimera. Chimera has a single pedicle with several branches, but Orochi has additional vascular anastomosis and combination with the multiple flaps. The name of Orochi comes from the Japanese names. Big snake with 8 head, and this looks like a combined tissue transfer with additional vascular anastomosis. Also, this is the origin that comes from Japan. So far, we experienced the free pocket graft for crushed hand injury. Total number was 109 cases, and majority is the finger, also dorsal hand, also palmar and forearm coverage. And LT is most popular graft, and 50% of these LT was combined chimera or orochi type flap transfer. Also, nerve flaps also combined with other flaps also popular. For the transfer of the tissue, flap was 98, and 46 was the combined tissue transfer. And the 2 total necrosis and the partial necrosis was 3, completely almost the same as the conventional flap transfer. So in this case, a young man who lost distal thumb, including with IP joint. So free wrap around the flap with distal partial phalanx and also vascular PRP joint with extension of flexor tendons. The combined tissue transfer. This is the skeletonized long vascular pelvic and PRP composite wrap included to produce the IP joint. And this is post-operative result. So IP joint was successfully moving. This is the post-operative SP, show the vascular, show the interarticular space. Donor cycle is covered with the split thickness skin graft. So this case was traumatic injury by the electric sole. So PRP joint of the middle window are missing, and also PRP of the index show the contractures, soft tissue contracture. So DIP joint of the second toe with first web space flap to cover the index contracture was transferred in one stage. So this is also the combined chimera flap surgery. So this is the post-operative result, and PRP get the ROM. Also, LT flap was very useful hand coverage. The thin flap with primary departing, and also short pelvic T pedicle was very useful as a close flap. So this case, 25-year-old woman had lost the total finger, excluding little finger, and she was crying. So I took the long range of the index finger and transferred to make long range of thumb to establish the grasp and also fingertip pinch for using the fingertip. But the proximal portion of the toe need coverage by the skin flap. So deep inferior circumference iliac perforator flap was elevated because the SCI was missing. So this very, very small 0.5 millimeter pelvic vessel. So this was transferred and pedicle vessel is anastomosis to the power of first metatarsal vessel, so power anastomosis was established. This is a completely origin concept with additional vascular anastomosis and the combination of flap was established. Also in the next step surgery, free LT flap to make a web space, wide web space, and pedicle T portion was anastomosis to the radial vessel as a flow through vascular anastomosis. So this is the final result. So chicken grasp and also pitch with the both fingertip was possible. So the also young woman with a model of company lost the soft tissue, including the extensor tendon. So extensor tendon was repaired with radial artery perforate article fascia flap, and also the second surgery after the splitting this past year, one area was covered with top flap from the lateral structure area because this area is conceived no exposing area acceptable donor size. And this flap has no muscle component, so pure powerhead flap for those artery, pure powerhead flap, and transfer to the dorsal pen. And after the aesthetic contraplasty and the multiplasty, she can extend the MP joint without any contraction, the full flexion is possible. This young man lost the proximal portion of his thumb, including the shin joint and soft tissue. So cup flap, including with scapula bone, was transferred to repair this big defect. And advantage of the top flap is to preserve the motor nerve or latissimus dorsi muscle once the reconstruction using this chimera type flap transfer. And this is the post-operative research. ROM of fingers. This case, regulatizing fasciitis 4 months after primary skin graft, another university hospital, and transferred to our department. So the primary contralateral LV-MC flap was transferred to cover the dorsal aspect of the forearm. And secondary surgery combined top and skip, long vascular pedicle flap elevated with preserving the sort of dorsal vessel. And this flap transferred to rotate from the upper arm to the forearm, Plexus side, and distal ACI pedicle was anastomosis to the radial vessel at the wrist region into side anastomosis was they start. Donor side was closed directly. So this is the aesthetic surgery whole contracture of the forearm, also upper arm was released, and finger flexion and extension was completely regained. This is 5 years after surgery. Also, right and the posterior view was very nice. All mesh skin graft was replaced with the graft, and also donor site was closed directly. This case was a young woman who lost the dorsal aspect of the forearm with heat press injury, 1 hour with 100 centigrade with compression, heat compression. So sensor tendon also radial bone are missing, radial artery also missing. So fibula, osteo tendon, neurocutaneous swap was transferred superarterial to peroneal tendon to produce the sensor tendon, and also sural nerve for the superficial radial nerve and the peroneal vessel transfer as a flow through repair of the radial vessel, and fibula for the radial bone defect. And 1 stage reconstruction, tendon, bone, and nerve, and also artery. Everything was repaired. And this portion of the peroneal artery was also anastomosis to the distal end of the distal side of the radial artery. So this was a kind of orochi type additional vascular distal, additional vascular anastomosis was established. Orochi type combined flap. So this is the 2 years after surgery. Some RM limitation of it existed, but ADL was completely improved. So this is a summary. We are now a new era of super microsurgery, so new concept, power-header to power-header graft transfer, and flow through power-header graft and reverse flow power-header, and the chimera and orochi, additional vascular anastomosis, and the combined flap, power-header, and iron posal for aesthetic repair, and also nerve flaps are very, very important. And in future, nano microsurgery less than 0.1 millimeter vascular, and also nerve fiber anastomosis open the new era of hand surgery. Thank you very much.
Thank you, Professor Koshima. That was a great exposition of the wonderful work on perforators. I think we will have a lot of questions at the end of the session, and look forward to that. Can I request Dr. Daniels to introduce our next speakers, please?
Yes, of course. First of all, amazing talk by Dr. Roh and Professor Koshima. Thank you very much. And I want to say, or enforce that it's a great honor for me to be part of this webinar, Super and Nano Microsurgery by the Journal of Hand and Microsurgery. So thanks, Terence, for the invitation. For me, I'm aware that in Asia, this is where the limits of this field are being pushed. So this brings a special excitement for me. And this excitement is especially high as I am introducing the next 2 speakers, which we have. First, we have Dr. Tokio Kasai from the Department of Orthopedic Surgery at the Takamutsu Red Cross Hospital in Takamutsu, who's going to be talking about the fingertip replantations and pitfalls of hand surgery in hand microsurgery. I have had the honor to listen to one of the talks, and there are a lot of pitfalls and things we can learn from Dr. Kasai from this talk. And the second speaker who has successfully or finally joined our talk is Professor Matsunaga Narushima. I'm really very happy to listen to your talk today regarding the super thin flaps and ectopic replantation in the hand. You are currently working at the Miyu University Hospital in Japan, and I'm aware that since 2011 you started publishing regarding the pure skin perforator flap, which was back then one of the first eras of this field. So I'm really glad and excited about your upcoming talk.
Thank you, Dr. Daniel. Now I have made Dr. Kasai as the presenter. He can share his screen and then start sharing the presentation. Dr. Kasai. Dr. Kasai, please go ahead.
Yes. Okay.
There's an option. There's an option called share.
Shared, but I'm sorry. Mm,
こうシェアのボタンがストップビデオの横にありませんかね。
あります。ただ、これがオンになってなくて。
オンになって、he's saying that this is not on. Share is not on. So,
シェアボタンが。
No worries. What I can do is I have his presentation. I can play the presentation.
You allow him to.
Yeah, he can speak on it.
Button.
He can speak on it. I have the presentation with him. He can speak on it. Kasai, is it okay for you?
Yes, please.
Perfect.
Thank you. Oh.
In the meantime, I want to urge all the listeners to use the chat box if they have any questions regarding the speakers. We're going to collect them and we're going to reply to them after the talks have ended.
Meanwhile, can I request Dr. Narushima if we can go ahead with this talk, if he is ready with that?
Yes, please.
成島先生いけます？
シェアしてみます。
はいはい。成島 will share, yeah, we'll talk. Trying to share. Narushima is now trying to share.
That's great.
So this session may be a little bit difficult for Japanese. Oh, it's okay.
It's okay.
Okay. It's coming.
Could
Yeah,
you-
great.
Okay.
George?
Please go ahead.
Okay. Thank you very much for kinds of opportunity. My name is Narushima Sancho from Mie University. Today I'm talking about the super thin flap and ectopic implantation in hand. Okay. Then first I will be describe about the first perforator flap by the Dr. Koshima in 1989. But it's very important point that this report was published by the British Journal of Plastic Surgery. Because plastic and reconstructive surgery was rejected because the reviewers couldn't believe it. And also the first skip flap was reported by Robert Ackland in 1979. However, the commentary to Professor Ackland, the Professor Hari worried about the risk of vascular spasm, so the SCIA skip is too tiny to be anastomosed. But this means that if you understand the detailed anatomy and you got the advanced technique, you can do it. So I would like to talk about the skip flap anatomy and techniques. The first, the anatomy. This skip was elevated with the superficial or the deep branch of the SCIA and the superficial epigastrial artery and the lateral intercostal artery perforator supplementary exit. Like this. In detail, several paper was published. The first, the incision is parallel to the growing ligament below the 1 centimeter. Then you can detect the SCIA and SCIV. Second, the elevation was performed in the intermediated dissection method. This meaning is like this incision, then the last is a micro dissection method. You can dissect the pedicle under the microscope because it increases the thickness of the adipose layer near the pedicle, so it is easily bleeding around the lymph node. Then last, the connection between the deep and the superficial branch is very close to the pedicle, so you need to use the microscope. This is a movie. After elevating the flap, then you can check in the pedicles under the microscope. Then you very concisely check the pedicles and the breathing part. So you need to check in the pedicles more carefully. But you can use like these electric scissors and bipolar. Then this is a case of 26 years old bone injury case. The skin defect was treated by the mesh skin graft, then contracture happened. So we performed the thin skip flap for the elbow. Then we elevated like that. Then transfer to the elbow area. The first contracture was treated like this result. Then this procedure modified to the ectopic implantation as a pedicle. The ectopic implantation was first reported by the Godiner, who implanted the subtotal amputated hand in the axilla in 1986. So we applied this procedure to the finger. The 30-year-old man suffered from a mangling injury of his right hand after it was caught in the meat grinder. All fingers were severely crushed with the exception of the little finger. So we preserved this little finger several times. We performed the ectopic implantation for the little finger with the skip. The skip 0.4 millimeter and digital artery 0.6 millimeter was anastomosed. Then subdermal vein and 2 dorsal digital vein were anastomosis with using the IVAS procedure. 3 months after, little finger was elevated with a skip flap 12 by 3 centimeter containing the lateral femoral cutaneous nerve. Then the right second metacarpal bone with the dorsal metacarpal artery was harvested and placed distally on the fifth metacarpal bone. The SCIA and the SIA originate from the common trunk which was anastomosed to the base of the fifth common digital artery. Like that, anastomosis was performed. Very complicated. Then we perform the two-to-hand transfer. Then he can use this hand. Unfortunately, he couldn't recover the whole finger, but he could get a pinch function. This procedure can perform the bilateral ectopic implantation too. Then, thin flap things continued. This is the reason because I should start this thin flap. 10 years ago, I operated AVM case. After resection of the AVM, I performed the traditional growing flap transplantation. Flap was completely survived, but flap was very bulky and it was impossible to use before defatting. We needed to perform the 6-time defatting. Slight bulkiness and the stiffness of PIP joint was remained. This case because a key point for considering the flap thinning. The thin flap concept was published by the Coulson in 1967, Thomas in 1980. If the subdermal plexus is undamaged, the flap was an adequate blood supply. So thin flap needed to include a fat layer for preserving the subdermal plexus. However, I noticed Imani's proposed subdermal plexus should be called deep dermal plexus because subdermal plexus was found either in the subdermal plane or in the deep part of the dermis. For this, we considered to preserve and use a pure skin perforator which penetrates the dermis. We considered to develop the flap without subdermal fat tissue. Appropriate flap elevation area was considered. Eyelid and penis prepume are the very thin skin thickness. However, these two areas are not practical. A third thin area is inguinal region. This is a skip flap part. Bulky. So, this is a PSP elevation method. Then we need 3 thinning technique for success of PSP flap elevation. First is a micro dissection. Second is a primary thinning. Third is temporary cramping. This is a movie. First, we are checking under the microscope, then separate the superficial layer, then we found the penetrate the perforator to the dermis. Then we are cutting all of the fat layer by the scissors. During the scissors cutting, we need to temporarily clamping on the pedicle trunk for saving the bleeding. Okay. This pure skin perforator flap is a skin flap with a subdermal part. Usually this thickness is thinner than 2 millimeters. Then we checked intradermal network is independent without any subdermal plexus. Intradermal branches of the PSP demonstrate the direct shunt to the deep dermal vein. So this is a reason that this pure skin perforator can survive without subdermal plexus. Recently, the Dr. Hayashi reported ultra high frequency ultrasound in planning capillary perforator flap. So we can use these techniques for the PSP flap elevation more concisely. Then this is a 36 years old male, some AVM, breathing, training, unusable. So we plan the AVM resection and defect coverage with a skip PSP flap. First, we resecting the whole AVM. Then we elevate the lateral eye cap and 15 by 4 centimeter CIP PSP flap. Pedicle length was 9 centimeter. This is a figure. The SCIA partial PSP and LICV to subdermal vein as anastomosis. SCIA superficial branch 1.0 millimeter was anastomosed to the radial arterial branches. Unfortunately, sensation recovery is still not enough, but satisfied the result because he was released from the bleeding and pain. He can use left hand freely. 61 years old male, middle finger AVM. He also severe pain and bleeding and high risk of finger ulcer. Skin and subdermal tissue middle finger, including the digital artery and nerve, was removed. Then 10 by 6 centimeter SCIA PSP flap was elevated. The PSP flap was covered defect of my middle finger. The 2 years after, also color and texture are different from normal finger. The shape is not bulky and didn't need secondary defatting. And functionally normal. However, aesthetic problem is remained. They doesn't have a nail. To be honest with you, we would perform the two-stage surgery. First stage, resection nail bed is preserved on the groin. Then 5 years after confirming the recurrence, the skip flap, the two or second to transfer would be performed. Then skip flap with nail transplantation will be performed. So first operation, we perform the nail preservation on the groin. The shape is not so good, but nails are growing. But we couldn't secondary operation because they were satisfied with the result. They didn't wish to have second stage operation. So I decided to preserve the next case, the nail. The nail was preserved. Then shape is not so good, but nail regrowing. This is the last case. 30 years old female, the foot AVM. Very severe bleeding, so she couldn't walk because of the pain. She was recommended an amputation of the foot in another hospital. So she asked our hospital as a second opinion. CT shows that the medial plantar to great toe were occupied by the AVM. So we decide the dissection area by ICG PD camera. After resection, then we performed this PSP partial flap coverage. Then 10 months after, AVM was completely resected. This is 2 years after. We performed a shortening of osteotomy and flap modification. She could get the pain relief and walk freely. This is a summary. The main SCIA diameter ranged from 0.7 to 1.0 millimeter. PSP diameter ranged from 0.1 to 0.2 millimeter. Flap size varied from 3 to 90 centimeter square. The thickness of the PSP flap were around 2 millimeter. This is a summary. PSP flap is thin like a skin graft. Left contracture, no secondary defatting. Then this flap harvest performed to the non-vascular area. If you elevate non-vascular PSP flap, means like a skin graft, you can also elevate fascia flap with a deep branch of the SCIA. Then this fascia flap anastomosis, you put the skin graft on this fascia flap. This is 5 years after result. I published PSP anatomy paper in 2018. 2018. My mentor, Professor Koshima, believed me. So just say, do it. And also, commentary to the PSP disc flap paper, Professor J.P. Hong encouraged me. So, advice for your future. If your senior said, don't do it, you should consider the reason and the resolution. If you are the senior, junior are depressed, you should encourage them, and every time you should say, "What's new? Do it." Thank you very much.
Thank you very much, Professor Narushima. This was an amazing talk and very enlightening to us to listen about the pure skin perforators from the first hand. I think next we may play the video of our final speaker, which is Dr. Tokio Kasai. I hope Jerome will play it.
We will try a last moment. I mean, if you could go ahead with the live presentation. Kasai, Dr. Kasai, I have made you as a presenter now. Could you please try sharing your screen this time? There's an option at the bottom called share.
Oh, yeah, yes, but I'm sorry, and I could not share. So, and could you please align your slide, please?
No problem.
Dr. Jerome, and could you please run my slide?
No problem. We will take some questions. Dr. Biswas and Dr. Daniel will take some questions. Meanwhile, we'll sort out this presentation and we can have the last presentation. We'll take some questions.
I think Dr. Biswas, you're still muted.
an astounding talk. Dr. Roh,
Yeah,
now in your perforator to perforator ALT flaps,
yeah.
do you do any localization prior to your surgery, like using ultrasound or high frequency ultrasound, or you plan it on the table?
Oh, we usually use usual ultrasound, maybe 20 to 30 megahertz. We didn't use
Okay.
some, brand new ultrasound. Yeah.
So you don't. So those perforators are dissected suprafacially.
Oh, the perforated flap, the diameter of perforated is super thin. It may be late 0.8 millimeter or 0.7 millimeter, and the vessels are super vulnerant to spasm. So we usually check the blood flow of donor vessels or recipient vessels, and we select the vessels and we cut the vessel usually over the facial level, superficial level.
So you have shown very small ALT flaps.
Yeah.
Okay. So in your small ALT flaps, how do you thin those flaps? If you read certain articles say that the perforators start branching at that level, can you thin those very small flaps?
Pardon one more time, please. I can.
Your flaps are thin.
Yeah.
Okay. So how do you thin very small flaps? Do you not keep tissue along with your perforator?
Yeah, we usually cut the abundance subcutaneous fat around the vessel.
So when it is small, is there a risk of injury to your perforator?
Yeah, maybe it has some injury of the vessel, but we carefully, meticulously dissect it and we remove some abundant subcutaneous fatty tissue.
Do you do it under the microscope or otherwise?
Yeah, under the microscope.
Okay.
Yeah.
Dr. Biswas, we have this Dr. Kasai's talk. Dr.
Yeah.
Kasai, can you just go ahead with your talk? I'll move the slides. Please go ahead.
Okay. Perfect.
Okay, I'm very sorry to the delay for joining you, and so thank you for kindly inviting me to your Jana Club Webby. And my presentation is about replantation trend and safe surgery in trauma. Next slide, please. Excuse me. Next slide, please. Can you move to the next slide? Okay. So, and next slide, please. I have nothing to disclose then. Sorry, next slide, please. Okay. And I'd like to start by talking about the recent outcomes of replantation based on my experience. I have reviewed 57 consecutive cases of patients who underwent replantation with an average follow-up over the 5 years and 11 months period. Proximal replantation were performed on 12 patients. Finger replantation were performed on 45 patients to 48 fingers. Results, the overall survival rate was 85%. According to the level of amputation, the survival rate was 92% for major replantation, 83% for thumb and fingers, 91% for fingertip replantation in zone 1 and 2, 76% for fingers in zones 3 to 5. Regarding motor function assessed with use of % total active motion, upper arm was 39%, forearm was 47%, a hand was 59%, finger reprint in zone 5 was 93%, zone 3 was 71%, zone 2 was 86%, and zone 1 was 89%. Excuse me, can you move to the next slide?
Please go
Dr.
ahead. I'm
Jerome,
saying this.
I'm
Yeah,
sorry.
please go ahead. Please go ahead. You want the next slide?
Next slide, please. I'm sorry.
No problem. Please go ahead. Is it okay for you? Dr. Kasai?
No, Dr.
Yeah,
Kasai,
yeah.
asking terrorists, please move. The next slide. Kasai
Dr. Jerome,
cannot move. Yeah, cannot move.
I can't move on to the next slide, so
terrorists,
please. Sorry about
please.
that.
Is this
Dr. Perez,
is this slide okay, or you want to go before or after?
And the next result
after.
after, yes. Oh.
You want to go the before slides, previous slides?
Next slide.
Next slide. Jerome?
Yes.
Next slide.
Next slide, please.
Jerome.
Is it okay?
No, it is not moved. It has not moved.
Yes.
Can you move that slide?
I'm seeing a slide with case 1 forearm.
No, it's not seen here.
Okay.
Not seen here.
Or yes, and result 3, please.
Okay. Can you see the slide now?
No.
Result 3?
No.
Next slide.
I'm trying to move all those slides. I could see the slides.
It's not coming on the screen. It's not coming on the screen.
No problem. I'll try and share it again.
Share it, please.
So, Professor Gotham, please ask some next question.
Okay. Okay, Dr. Koshima.
Yeah.
Your talk was wonderful. As usual, it is remarkable. So when you do your Orochi flap, is it planned during the surgery? Because you really don't know where the perforators are. Or do you plan it before?
Before the surgery, I always plan. If there is a huge defect, composite defect, I always prepare. But actually, sometimes it's a change because sometimes the pedicle is short or the size of the pedicle is not much. So in that case, we must change. So every time we must change everything. The anatomical variation also. Sometimes we need a vein graft.
Okay.
Yeah, sometimes another need other option, nerve wrap and something, because the majority of those cases is not only the plastic surgery, the oncologist always ask many things, order everything. So that's why we must always change and do the best result.
So you frequent.
Yeah, sometimes we need not so long time. In that case, we must do the short time reconstruction. So we must change sometimes change my policy.
So you frequently change your plans.
Yeah, during the surgery. Yeah,
during
so
the surgery.
before surgery, we must explain the many things, many methods, many plans to the patient, also families.
And Dr. Koshima,
Yeah.
do you link up these vessels while the main pedicle is still being perfused, or you do it on the table after detachment? You join your flaps while it is still connected to the donor site, or do you detach it and then join your flaps? Means you transfer it and then join your other flaps, the other flap, second flap, third flap. What do you do? Or you do it on the donor site?
Oh yeah, I took the different portion, different donor, and combine in the recipient side.
Not on the table. Do you do it on the table outside the?
No,
after
no,
detaching?
no, in the body.
In the body only. Okay,
Yeah.
okay.
This is very important point to shorten the time, surgical time.
So what is the time you take to do these procedures?
Yeah, we always do the simultaneous flap elevation with tumor resection or recipient preparation. So usually 7 hours or 8 hours.
Oh, that is good.
Yeah. So such a plan. Also, not only a single microsurgeon, 2 or 3 professional microsurgeon necessary.
Fantastic. Are we ready with the presentation?
Dr. Biswas, can you see the slide right now?
I can see result 3. Result
I'm
3.
coming back.
Okay.
Okay.
Go ahead.
Okay. And in respect to sensory function, there are 2 key points. And the firstly, upper arm and forearm mostly are recovered to S2 level of sensation. Secondly, the median nerve sensation had obtained better recovery more than the ulnar nerve sensation. Okay. Oh. Oh. I'm sorry. Freeze again.
Oh, next slide.
Can you see the result 4 slide?
Dr. Jerome, and could you help me?
Yeah, I have moved the result 4 slide,
but it is not showing here.
Doctor, you can take some questions probably here.
Okay.
Can you try, Dr. Kasai, now? Can you try your slides now?
Okay.
Is it okay now?
I could not. No, I can't.
Okay. Could you?
Freezed.
Okay, no problem. Just could you stop share? I'll try it again. Could you stop sharing it? I'll try it again.
Thank you.
Dr. Daniels, would you like to ask?
Oh yes, I've got after this talk a lot of questions which I want to ask. Maybe I will ask Dr. Solji Roh. You have actually showed in one slide that you are using the ultrasound at the beginning for the planning. Can
Yeah.
you possibly explain to us what kind of ultrasound you find comfortable for designing on the ALT? Like what kind of megahertz probe you would prefer, and is there any special technology? Would you go for the ultrasonography like Dr. Hayashi, or what kind of tips can you give us?
Yeah, these days many doctors, Hayashi Akimachi or Hiramachi, Dr. Hayashi uses some 70 megahertz ultrasound, but we always use usual ultrasound. Maybe it's 15 to 20 megahertz. And also I heard some 70 megahertz ultrasound is not good for cells of the tissue. Yeah, it has some cell toxicity. So we usually use my common ultrasound, and I think it's now it's great to identify perforator. Yeah, it's good, sufficient enough.
Thank you. Do you also use other technology like ICG? Would you say that ICG and ultrasound are essential for your ALT designing, or you only rely on ultrasound?
Yeah, we use ultrasound and we use ICG and we use hand Doppler and we use CT. And the perforator is very thin and it's vulnerable to vascular spasm. So it's important to check the blood flow, and not only blood flow, blood velocity is also important. So we check the donor side and both donor and recipient side, the blood flow, blood velocity, and all the information we can get.
Okay, thank you very much. Maybe I would like to ask Professor Narushima another question, if this is possible. I was really amazed that you showed us that you specially dissect under the microscope the final part of your PSP flaps, and I think this is a very important and crucial step. If you don't do it, you'll only get frustrated by the blood around the lymph nodes. And I was also fascinated about regarding the amazing work with the ectopic finger replantation. I would like to ask you, how is the success rate from your experience, or would you rely on PSP harvesting from the ALT? Like, do you favor the skip for the PSP, or can you do it from any flap on the body?
Thank you very much for your question. We already performed the ALT flap and published by the Karakawa for the ear reconstruction. It's a similar procedure was possible to use for ALT and another place. However, the thickness of the dermis and epidermis is thicker than the growing area. So for example, I tried to use the thoracoabdominal flap for the covering the face burn injury. Around that things, we perform the eyelid area as a partial PSP flap. However, this thickness is very thicker than the normal eyelid, but contracture didn't happen. So maybe like this situation, you can try use for this PSP procedure for another flap.
Dr.
Thank you very much.
May I ask a question, please, Dr. Professor
Yes.
Narushima?
Yes.
When you use your super thin SCIA flap,
When?
do you use the vein accompanying the artery, or you use a superficial vein?
You mean the accompanying vein or the
Yes.
SCIV?
Yes.
It's very important for this procedure. I was afraid about if we didn't use SCIV for this drainage as necrotize. However, it's not happened even if we doesn't use the SCIV. Just use accompany vein is enough for the survive of this PSP flap.
And you showed a lot of patients with arteriovenous malformation.
Yes.
Okay, so
because this is my next subspecialty of the this vascular malformation treatment.
So
Yeah.
the recipient vessels in an AVM are usually affected. They are thick-walled. So do you have any tricks and tips, or you go into a different set of vessels?
It's a very important point for this because sometimes the AV malformation reconstruction using the flap is a high risk of the venous thrombosis after the operation. So we usually anastomosis the two vein, each one flap for this reconstruction, and we usually post-operatively heparinization of the 1 week by just 10,000 unit per day. Yes, this is one trick, one secret for this success of the flap survive.
Okay. Any other questions?
I think there is a question from the listeners which is similar to this one from Carlos Gutierrez Novoa. He is asking Professor Narushima, what is the post-surgery protocol you use if it's not AV malformations? Are you use aspirin? You use other tricks, heat blankets? What is your standard regimen?
You mean the post-operative?
Right.
Yeah,
right. Anticoagulation, aspirin.
Yeah. One is heparinization, and then the prostaglandin is used for the 1 week. Yeah, 40 microgram per one time by 2 times per day. Yeah, 1 week. It's this is but this procedure usually used for the another flap and another operation for reconstruction normally. But we usually opt the heparinization for venous, vascular malformation case.
Okay. So as a standard protocol, you use 40 micrograms of prostaglandin, like 101 in the morning and in the evening as an infusion.
Yes.
And this for 7 days.
Yes, exactly.
Okay. And final question also from the audience, from Amrita Kaur. She is asking you if ICG or infrared thermography are used for all PSP flaps before detachment or after the anastomosis at the recipient site.
Usually I use the ICG imaging after elevation of the just the elevation with the fat adiposal cutaneous flap elevation time, because we would like to detecting the PSP penetrating the dermis or not, checking. After elevation, a little bit thinning flap, then we perform the ICG imaging. We detecting the real position of this PSP area. This is the reason for using the ICG imaging mainly.
Thank you very much. And I have one final question from the audience to Professor Narushima, and maybe also Professor Koshima can tell us from his experience. This is from Muhammad Omar Afzal. He is asking, if you are making a very thin flap, like the pure skin perforator flap or very small flap, is it possible to make the anastomosis to the venous plexus or to the venous system to make it like a venous flap, or would you just usually respect the anatomy and make artery to artery and vein to vein?
I haven't ever experienced to the venous flap for this procedure. However, for the finger, maybe it's possible to use, because the fingers, vein and artery is sometimes a pulsation exists. So maybe like this situation may be possible. Please try. And could you tell me after the result?
Okay.
Thank you so much.
Thank you very much. I think now we can go back and try one last time with the Dr. Kasai, and we hope that the connection this time is going to work well.
Okay, and I'd like to start again and on sensory function after finger replantation. As for finger replantation, the sensory recovery score shows that replanted distal fingers in both the zone 1 and 2 have obtained excellent recovery. Oh. I don't know. I'm sorry.
I think it's getting a problem. It's not persisting. This problem is persisting. So,
oh.
I think that's the problem with these web meetings.
Okay. Okay. And I'm sorry. And a comprehensive and functional evaluation of the proximal replantation, according to change criteria, reveals that 67% were good and 33% were fair. Tamai's evaluations score for thumb and finger replant shows that 71% excellent, 20% were good, and 9% were fair. I'd like to show you example cases. This is a 22-year-old male case of left forearm muscle lesion amputation by a railroad accident. And 2 years at 6 months after surgery, he has recovered to grade 2 of a good rebel according to change criteria. This is a 31-year-old female and a case of zone 1 amputation of right middle finger. The amputation was distal to arterial arch. Therefore, I did anastomosis to paramedian pulp artery with vein graft harvesting from distal forearm. After 3 months post-op, the function and the cosmetic outcomes were excellent. In summary, protective sensate upper arm and forearm, which were deplanted, have useful recovery as the assisted arm, even if motor function was fair. The survival rate and outcomes for zones 3 to 5 were relatively poor compared with those for other distal zones in the finger. For fingertip replant zone 1 to 2, in addition to clinical outcomes, patient satisfaction was also high, leading it to conclude that fingertip amputation should be replanted. Oh. Okay. I'd like to focus on the technical tips of the finger replantation. Okay. Oh. I'm sorry, I could not advance Dr. Jerome.
Professor, could you just read out your text? Then maybe that will also convey the message.
Okay. My technical points and distal transversal palmar arterial arch and called DTPA is a crucial and anatomical landmark. So okay. Okay. Finally, and I just say, okay.
Dr. Kasai, one small question. Is this the correct slide for you right now?
I'm sorry.
We're seeing methods of arterial repair. This is the current slide. Is this the correct one for you? Or which slide do you see on your monitor?
And this slide?
Yes. Is this the one you want right now, or should we go to the next?
Yes. I showed them the entire upper extremity and outcomes of the replantation. Of course, and as you know, and fingertip replantation is very good and cosmetically and functionally. A technical point is arterial repair of the fingertips. And I prefer to do the vein graft frequently. So, and vein interposition vein graft is make easier to anastomose. That's my point. So, but sorry, and
thank you, Dr. Kasai. Sorry for the technical problems. I think we were anyway. We've seen your wonderful work. I hope the audience has some questions for you. So may I start by asking again, what is your post-operative protocol for fingertip where you're using vein grafts?
And so, drugs or and
yeah. What do you do post-operative?
Okay, and heparin, and maybe usually I used 5,000 units to 10,000 units per day, and for 5 days.
Okay. And that's it?
That's it, yes.
That's it, okay. So you don't use prostaglandins here, right?
Prostaglandin, sometimes I used, yes.
Okay. So what let me ask the audience, what are your views on the newer heparins that are now proposed, like enoxaparin? Is anybody using these drugs in lieu of heparin per se?
Yes, yes.
Long-acting heparins?
No, and no more. Not raw molecular heparin.
Not low molecular heparin. Okay.
Okay.
So your sensory recovery, as you charted out, are really good. I mean, obviously, fingertip are aesthetically and functionally much better.
Yes.
Functionally than in the other zones, which are much more proximal. Any further questions, Dr. Daniels?
Yes, I would like to ask you regarding your work. You emphasized that it is very important for you to go for the vein graft rather than anastomose immediately. How do you deal with the osteosynthesis? Do you make it at the beginning of the vein graft or you make it afterwards? What is your sequence?
Okay, that's a very good point. And vein graft first, and then osteosynthesis. Yes, that's a very good point.
Thank you very much.
So I think any other questions? I don't see any further questions.
Yeah, this is my comment.
Yeah.
Especially in the crushed fingertip replantation.
Yes.
I proposed maybe 10 years ago. I proposed delayed venous anastomosis.
Okay.
Yeah, first day we try the only arterial anastomosis, and the next day the backflow to the vein becomes strong, and the vein dilated. The first day vein has no flow, so it's very difficult in the first day. So, but second day, it venous drainage, vein become expand and become a big diameter. So it's very easy, and success rate of venous drainage is very easy. Only, and also every time I use the Gita block, so we can get the high success rate. Delayed venous anastomosis is a key point. This is my comment.
I think that's yes. How many times have you all not done the vein, allowed it to bleed, and later on it just linked up? You know, some people say just do the artery and a very distal replant, and get the and remove the nail, and you use heparinization.
External bleeding. Based
External
on my experience, it's not so good.
Not
The
so
success rate low. Accurate venous drainage is very, very important.
Okay.
Even the fingertip replantation.
Okay.
Also, venous vein graft is also very, very important technique. And also, sometimes we are using the distal arterial backflow to the proximal vein. So this is also very important technique.
What kind of donor site would you prefer? Like, I'm going to ask the panelists altogether for the veins. Do you usually use the lower arm or the leg or somewhere else?
Wrist joint, palmar side of the wrist joint. They're very nice 0.3 millimeter small venules. So also the donor scar is conceivable. The transverse incision. So this is very nice. But probably female, young female, we should take the dorsal foot. But
Okay.
yeah, palmar region is very convenient.
Okay. Thank you very much.
Professor Koshima, may I ask you? I mean, you're doing very small perforator to perforator flaps.
Oh yeah.
Are you you do have a set of instruments that you have you have promoted?
If you use a 50 micron needle, we must use a super micro instrument.
Instruments. Okay.
Yeah, special instruments. And also nowadays we are using the 30 micron needle.
Oh.
Only 1 millimeter in length. This needs a more small nano micro instrument. So we can anastomosis 0.1 millimeter invisible vessel anastomosis. So now I'm doing the free nerve flap with vascular anastomosis. Feeding vessel is nerve arterioles outside the perinoeum. Also, recipient vessel is feeding vessel of nerves. So this is the nano micro nerve flap transfer. Also, lymph channel transfer. The feeding vessel lymph channel is also 0.1 millimeter. So super micro to nano micro would be a next topic. Everything becomes smaller and smaller. Also, micro robot in the European country now they're using. So with a micro robot, we can go into the nano micro era. 0.1 millimeter vascular anastomosis is now possible. Also, nerve fiber could be anastomos. So nerve bypass could be possible. Even the median nerves are sacrificed. Ulnar nerve transfer, nerve fiber or nerve vascular transfer makes the completely normal mobilization of the median muscle nerve. So everything will change. So bypass surgery will be started. Vascular bypass or nerve bypass, lymph bypass, lymph venous bypass, everything. So human anatomy could be changed by super microsurgeon or nano microsurgeon. Everything will be changed. Revolution will occur.
Thank you, Dr. Koshima. I think that is the inspiration to the young guys who are here in the audience that will stimulate them to work in this area. I think we have the slides now. I think we can take a one last chance and see this exciting part of the last talk. Dr. Kasai, is that okay?
Oh, yes. But again, and I could not advance my slides, so I'm very sorry about that.
Maybe we can help. Please tell us which slide you want to advance to.
Okay.
Is this advancing for you?
I'm sorry, I could not.
Okay, can I advance it for you?
Oh, okay.
Now it's working, I think.
Yes, and what is working?
Excellent.
Yeah, as you can see, and as I mentioned, and distal transverse palmar arch is crucial anatomic landmarks, and CPA and central pulp artery, and usually and 0.5 millimeter in diameter. I'm sorry, I could not.
Next slide.
No. This is the methods of the arterial repair, and if and the DTPA is remained, and we can and transposition the arch and arch stump to distal artery, and end-to-end anastomosis is possible. And if DTPA is lost, and my history is 92%, and vein graft were needed. So, and 62 years old man, complete amputation zone 1, and vein graft to the central pulp artery first before osteosynthesis. And then grafted vein anastomosis to the stump of proper distal artery. I cannot. Oh. You can see the breathing after arterial anastomosis and 3 months post-operatively. And the arterial repair method was determined according to whether DTPA was intact or not to every determination of the need for vein harvesting and appropriate anatomic site. The last one is my 7 key points from Ferry mode analysis. As you know well, and flap selection is crucial, and the recipient and donor vessels with good flow selection, attention to vessel tension, meticulous hemostasis, and the flow through type arterial anastomosis if possible. Keep 2 veins outflow and frequent flap circulation check within 72 hours post-op, frequent especially. And I'd like to stress on appropriate flap selection, skin design, maximize the inclusion of the perforator in the flap. Look at the whole vascular network, not just a single branch, to keep a variety of transfer and perform another rescue flap. This is an example, and subscapular artery based flap vascular tree. And we should look at the whole vascular network. Thoracodorsal artery based flap also, and we can harvest rotatum dorsal flap and scapular flap, and based on the angular branches, and throat anteromuscular flap with a segment of the rim. And I prefer to do the flow-through type arterial anastomosis if possible. There are 2 advantages. One is to preserve the main source artery. And number 2 is a possible chimeric flaps for a complex reconstruction. I show on the vascular fibrograft and rotatum dorsi flap. And I'd like to emphasize on the surgical approach using the vascular zone concept designed for maximized and increasing of a perforated rich area in the flap. So, okay, thank you. And I believe the best combination of the strategy and the skill make excellent result. Thank you so much, and sorry about my presentation. So, thank you.
Thank you very much, Dr. Kasai. It was worth waiting for the slides, and I'm really glad that we went through them and saw your nice pictures. I would like to ask Dr. Gautam Biswas if he has any further questions.
No, I think thank you very much to all the speakers, and Dr. Daniels also, as being the host, and we apologize for the technical issues that we had today. But let me first thank Dr. Roh for her excellent presentation on the ALT flap perforator to perforator. These are actually areas which we are going to explore, and probably it revolutionizes microsurgery per se. I would also like to take this opportunity to thank Professor Koshima. I think we often meet, our roads cross during meetings, which we have not had for the last 2 years. So unfortunately, this is an opportunity to see him and meet him again. This new technology of webinars, which we have become familiar with. He has always been a brilliant teacher, a mentor to many plastic surgeons, and has really revolutionized the thought process. I think one of the slides did show that a review of one of his articles, people did not believe it and was not accepted for publication. That just goes to show he is at a far different level than we are thinking about. So nano microsurgery is something which is, at least for me personally, still not comprehensible. But Professor Koshima has reached that territory, and I hope this will inspire our young minds and young guys to come in and explore this really exciting territory. May I request Dr. Daniels to thank the other speakers, please.
Yes. One more time, thank you, Professor Koshima, for bringing up all these pioneers following you. And you have definitely advanced the whole microsurgery area. And special thanks, of course, to Professor Matsunaga Narushima. I'm really glad that I finally met you today, and it's really enlightening to know what is feasible with the pure skin perforator. And also thank you for the tips and the practical tips which you gave to all the audience today. And one final thank is to Dr. Tokio Kasai. Fingertip replantation were actually the makers of super microsurgeons, and it's very important that all the young microsurgeons be good at them, because this is the best way to train, if we can say, in this small circle, and it is also very satisfying for the patients when we can help them with this. Finally, I'd like to ask if the panelists would like to add anything at this point, or we will later then close this meeting.
Okay.
Thank you very much. Thank you.
I think we thank the speakers and thank you very much, and we will conclude our session, and we'll hope to meet all of you physically next time.
Yeah. Thank you.
Bye. Good night.
Bye.
Good night. Thank you.